Hi everyone. My name is Aynur Guluzade. I am a student from University of Bonn in Germany, and today I'm going to present our work, which is demographic-aware probabilistic medical knowledge graph embeddings of electronic medical records. And I would like to start a brief introduction about our work. And yeah. So in recent years, knowledge graphs has been established for medical assistance, such as medical assistance as an underlying core component. And those knowledge graphs are often extracted from sources such as electronic medical records, which is real world data. And medical knowledge graph-based applications have been reported in different scenarios, such as different treatment recommendation, medicine recommendation, and drug-to-drug similarity measurement. Such applications usually are performed through a link prediction process and can be divided into two steps. Firstly, to learn embedding of medical entities and relations, and secondly, to make a predictions or recommendations according to these embeddings. And coming to motivation, while recent research employs traditional knowledge graph embedding methods, it lacks the consideration of demographic metadata, and such information is very advantageous and even necessary for medical tasks, which we have seen in the other related works. And in this work, we argue that incorporating demographics as part of medical knowledge graph allow us to retain patients' generic information and to construct more accurate representations for medical entities. And the contributions of our work are, we propose a framework which we call the Darling demographic-aware framework for learning probabilistic medical knowledge graph embeddings. And we provide a method to construct a medical knowledge graph with demographics metadata that links all entities and with existing medical knowledge graphs. We also demonstrate Darling's effectiveness through extensive experiments and show it is superior performance via link predictions on treatments and medicines. And I would like to give some background about the knowledge graph. A knowledge graph can be denoted as a set of triples, and here we can see K contains the subsets. K contains a set where E and R are a set of entities and relations respectively, and it contains the triples which H and T represent triples respective head and tail entities, and R represents its relation. And the direction of relation indicates the role of entities, either its head or tail entity. If you see the example here, which we illustrate, Bob lives in Germany. Here, Bob represents head entity, and Germany represents tail entity, and lives in is a relation between them. And for our work, we use medical knowledge graph. We consider medical entities extracted from electronic medical record data, such as diagnosis, disease diagnosis, treatment procedures, and medicines. For us, the set contains three sets. Our entity contains three sets, where D is a set of diagnosis, P is a set of procedures, and M is a set of medicines. And in particular, we construct triples. For us, head entity will be always belong to the diagnosis, and tail entities will be either in the set of treatments or medicines. And hence we can see also the example we show one medical knowledge graph triple example. For example, tuberculosis is treated with isomized. Tuberculosis is head entity, isomized is tail entity, and is treated with is a relation between them. And medical knowledge graphs with demographics. We incorporate patient demographics such as gender, age group, and ethnic group by adding a new demographic dimension. We defined the demographic set C, where G is the set of genders, A is the set of age groups, and T is the set of ethnic groups. And our medical knowledge graph contains quadruples, head, relation, tail, and the C, where C is the demographic set for which the corresponding medical triple holds. And we also added in our example, we also showed in previous slide, tuberculosis is treated with isomized, which is corresponding triple, for the demographic set where gender is here male and the age group is between 60 and 70 and ethnicity group is Asian. And finally, for our task, we consider probabilistic medical knowledge graph with demographics. And for that, we want to strengthen each quadruple existence by introducing a statistical probability. To do so, we associate each quadruple with a probability score P, which is calculated given the number of electronic medical record admissions the quadruple was extracted over number of admissions that contains medical entity H, which is head. And basically, the probability score indicates how likely is that particular triple will appear with the demographic set for specified disease or medical entity H. We also show example here. We are adding probability score as an additional after our quadruple, and demographic guided translation. Now that we have a probabilistic medical knowledge graph with demographics, we want to create embeddings. Here we want medical entities to have distributed representation associated with different demographic sets. We want to represent each demographic set as a hyperplane where we will have C number of different hyperplanes. And our intention here is to separate the space into different demographic zones with the help of hyperplanes. In this way, medical triples valid with demographic set C are projected onto demographic specific hyperplane where their translational distance is minimized. And here WC refers to the normal vector of hyperplane. Now, using the triple embeddings head relation tail, we want to project them on hyperplane WC, and we do it as shown in the equations. And we expect that a positive triple valid with the demographic set C will have mapping as head plus relation to be almost equal to the tail. In other words, we want head plus relation minus tail to be equal to 0. And this is also how our scoring function is defined. To illustrate this, we can see in our figure an example where medical triple tuberculosis disease to medicine isomized, where tuberculosis is the head entity and disease to medicine represents the relation and isomized the tail here. The triple is valid for both demographic sets that we can see in the figure. Hence, the triple is projected on both demographic set hyperplanes. As we can see, if we take as an example the first hyperplane with gender male, age group between 60 and 70, and ethnic group Asian, we can see the projection of head, which is in red color, plus the projection of relation, which is in gray color, is equal to the projection of tail, which is in green color. Now continuing with optimization, Darlings employs the margin-based pairwise ranking laws to differentiate between correct and incorrect triples. In other words, positive and negative triples, where negative triples are obtained by corrupting the positive ones. Formally, we minimize the following loss function. Here in the formula, we have 3 sets: demographic set C and positive triple set D plus and negative triple set D minus, and here G is our scoring function, which we will explain in the next slide. And Gx is scoring function for positive triples, Gy is scoring function for negative triples, and lambda is margin separating correct and incorrect triples. Now we continue with optimization through probability score. And Darling does not directly use the score function f, but it rather incorporates the probability into the learning process. The idea is here to use probability value p for estimating the scores. For that, we introduce a mapping function fp that allows us to map each quadruple probability value into a score. Basically, this mapping function will provide a low score for high probabilities and a high score for low probabilities. Specifically, the quadruple entities with high probability value will have a representation closer in space compared to those with low probability. And finally, we define the function GC, which is absolute difference of probability score FP and the score function FC. And coming to experiments, we are using data sets like Mimicry, which is medical information match for intensive care, contains information related to patients admitted to critical care unit at a large territory care hospital, and ICD-9, which is International Classification of Diseases, reading extracted diseases and treatments with ICD-9 ontology, which contains 13,000 international standard codes of diagnosis and procedures. Drug bank, we link the extracted medicines to drug bank, which is bioinformatics resource that consists of medicine-related entities. And here we can see the overview of the medical knowledge graph construction. We connect Mimicry and drug bank and the ICD-9 ontology by constructing the medical knowledge graph. Firstly, we extract medical facts from electronic medical record data, which is Mimic for us, and we create a medical knowledge graph quadruples, as you can see in the middle box. And after we link all diseases and treatments with ICD-9 ontology and medicines with drug bank. And experimental setup. We evaluate on link predictions for treatments and medicines on the constructed medical knowledge graph. We apply frequently used metrics to summarize overall performance like mean rank and hit at K. Mean rank, which represents the average rank of the test triples, where smaller values indicate better performance. Hit at K, which denotes the ratio of test triples that have been ranked among top K triples, where larger values indicate the better performance. And we report the results for K at 3 and 10. In next slide, we will see the table which illustrates the results. Yeah, as indicated, the Darling outperforms all other traditional knowledge graph embedding approach on both mean rank and hits at K. More precisely, for hits at 3 and hits at 10, our framework has an absolute difference for at least 5 points from the baseline, while hits at 3 on medicine prediction, the difference is increased to the 10 absolute points. And we can see Darling also has lower mean rank compared to all other baselines. We can see that for treatment prediction, we have mean rank of 64, while on medicine prediction, it's 22. And the improved performance of our framework indicates its ability to generate more accurate embeddings of medical entities. Demographic and probability score sensitivity. We aim to recognize which demographic category, gender or age group or ethnic group is more effective and whether the probability score impacts our results. And to adjust Darling, we adjust the Darling to construct hyperplane with all demographics individually and with all possible combinations. And we run experiments by including and excluding the probability scores. In this figure, we can see the results of these experiments I mentioned in the previous slide for mean rank in the hits at 10. Regarding the demographics, we obtained that age group is the most prominent one since the results are better compared to gender and ethnic group. And it also worth to mentioning that even when employing one demographic category together with the probability score, we will occur better results than any other of the baseline methods. To conclude the work, we focus on medical knowledge graph embeddings of electronic medical records, and we provide the demographic-aware embedding framework that leverages probabilistic feature of entities. And we also present a method to construct a medical knowledge graph from electronic medical records data. And we show that our model achieves the best results in the link predictions on treatments and medicines. We performed sensitivity experiments and discovered that age is the demographic category that significantly affects our high results. And finally, we show the importance of probability scores in our framework. Thank you, everyone.